preclinical work demonstrated that the combination of the hypomethylating agent azacitidine in particular, combined with ivosidenib, resulted in potentiation of apoptosis and increased hematopoietic differentiation compared to either agent when used in isolation. So in this study, azacitidine was added to the combination of ivosidenib, also in combination with the BCL2 inhibitor venetoclax, as IDH-mutated malignancies have an increased dependency on the anti-apoptotic protein BCL2. So the hypothesis is based upon the rationale that harnessing the observed synergistic activity with these agents in combination with the preclinical setting data, or the data from the preclinical setting that we have, and then of course now with recently reported phase 1b clinical data of the combination of ivosidenib and azacitidine, that was recently published in JCO by Dr. DiNardo demonstrating efficacy, that this doublet and triplet combination will result in deeper remissions and hopefully prevent relapses via some of the known resistant mechanisms to these agents when they're used as individual agents as monotherapy. Patients responded well to both the doublet and triplet combinations in this study. It's important to remember that ivosidenib increases the metabolism of venetoclax. So dose level 2, which was Ivo in combination with Ven at 800 milligrams, is more representative of a therapeutic venetoclax dose compared to dose level 1, which was Ivo in combination with Ven 400 milligrams. At dose level 2, and then also in dose level number 3 with the addition of azacitidine in combination with Ivo and Ven, we saw increased composite complete response rates with fewer relapses in the triplet combination arm. It is worth noting, though, that the triplet cohort had more newly diagnosed AML patients compared to the doublet arms, which may skew the results a little bit in favor of the triplet arm. But that being said, the complete remission rate for newly diagnosed AML patients overall, irrespective of cohort, was promising at 92%. The safety profile was what one would expect within a patient population being treated for a myeloid disorder, with febrile neutropenia and pneumonia being the most common infectious complications that were observed on study. Tumor lysis syndrome occurred in 8% of patients and was considered a dose-limiting toxicity in one patient, but fortunately both cases of TLS did resolve with medical management alone. There were 4 patients who developed the IDH differentiation syndrome, and similar to the patients with tumor lysis, all were successfully managed with medical therapy. But I think, clinicians certainly need to be cognizant of these unique toxicities, as although they are relatively infrequent, early intervention is paramount to avoid related complications. So we have just recently completed enrollment in our final dose level, which is dose level 4 of Ivo with Ven, 800 milligrams in combination with azacitidine for the phase 1b portion of the study. And so we'll soon be moving into the phase 2 portion. It really is an exciting trial, as the doublet and the triplet regimens demonstrate efficacy, and we want to maximize and ensure durable responses with a well-tolerated regimen for our patients. So the next steps will be to perform correlative analyses to determine if specific clinical or molecular features are predictive of outcomes with the doublet and triplet regimens. We plan to perform translational analyses to clearly delineate the mechanisms underlying relapse in those patients that are relapsing on the doublet and triplet, in order to determine if the combination therapies overcome some of the resistance patterns that are seen with single agent therapies that have been published to date. And hopefully this information will allow us to identify the best treatment and individualized therapy for each patient.